Good evening, everybody, and welcome to the next BSP webinar. I'm Ian Dunn, and I'm going to be your host for this evening. Before I introduce our speaker in the evening, I always like to run through a bit of housekeeping, as many of you will know from the previous webinars that we've done. Initially, I'd like to thank our sponsor for the evening, Johnson & Johnson. Huge thank you to them for bringing this presentation, this webinar to us tonight. I also need to remind you that we have the BSP Spring Meeting in Brighton. It's only a couple of weeks away now. Our President, Mark Ides, has put together a fantastic educational programme, and it's only matched by its social programme of an evening. And it would be great to see many of you there. I've been told today there are very few places left now, and I also need to point out that midnight tonight is the very last time that you can register at the reduced rate. And as of tomorrow, it goes up to the late registration rate. So when this webinar finishes, before you go off and watch and find out all the football results, make sure you log on to the BSP website and book for Brighton, and we will see you there. For those of you who've not been or tuned into one of the webinars before, the way this evening is going to work is that our speaker will speak for about 45 to 50 minutes, and questions can be asked typed through the control panel, and I will collate them and present them to the speaker at the end. It's impossible to do one-to-one questions, so I will deliver as many as I can on your behalf. Following this evening's webinar, you will be sent a link. Tamsin will send that out in the next couple of days, that will record your feedback and allow you to collect your CPD certificate. So don't do anything immediately after this. It's all going to be done through an emailed link in a couple of days' time. So on to our main event for this evening, and I'm sure many of you know our speaker. She is very well known, needs no formal introduction. So tonight we have Professor Nicola West from Bristol presenting on periodontal disease management, modifying diagnostic behaviour and communication behaviour for better oral health outcomes. Thank you, Nicola.
Thank you, Ian. It's a great pleasure to work with you, and it gives me great pleasure to present this BSP webinar this evening on periodontal disease management, modifying diagnostic and communication behaviour for better oral health outcomes. And I too would like to thank Johnson & Johnson for sponsoring this evening. So what we're going to do is look at the learning aims and outcomes. We're going to review the principles of identifying and diagnosing gingivitis, appreciate the importance of early intervention, and that really is the key message of this evening. We need to do something early to prevent periodontitis. Understand the BPE and how we use it, and then look at some self-administered oral hygiene and adjunctive benefits of chemotherapeutic agents. So everybody thinks they can clean their teeth, and most people think they do it reasonably well. However, in reality, people really don't clean too well. Look here at the photographs of the teeth. You can see there's a huge amount of plaque on, but when you look at the left-hand side, it looks like there's very little. Now, lack of oral hygiene and plaque control are predominantly responsible for the initiation of gingivitis, and conversely, excellent oral hygiene prevents gingivitis. And we know that many of our adolescents in Europe, and particularly in the UK, have gingivitis. They can just about get up in the morning, if they're like my children, by lunchtime, and the first thing they reach for is certainly not their toothbrush. It's usually their phone. If we look at adults, they are improving, and 40 to 50% of adults have gingivitis. It's improved over the years because of personal care, people being more informed, but worldwide, of course, it's still pretty high. It can be up to 70 to 100%. Periodontitis, again, is derived in the majority of cases from poor oral hygiene, and oral hygiene and plaque control are therefore crucial in the management of this condition. Peri-implant mucositis and peri-implantitis. We have figures for Europe for 43% of our implants having mucositis and 22% peri-implantitis, and those are high. And of course, we have links to systemic conditions. We know we have 57 associations now with systemic diseases and periodontitis. The ones highlighted here are the ones that have the greatest associations, and we know the links to diabetes, cardiovascular diseases, adverse pregnancy outcomes, and we have rheumatoid arthritis, certain types of cancer, that's pancreatic cancer, and dementia, Alzheimer's disease, which is where I'm working. And we think that Porphyromonas gingivalis, for example, is going up the olfactory nerve into the brain, and certainly is associated with a number of other things to develop dementia. There are three potential routes by which the periodontal disease could result in the systemic diseases. So we could get oral bacteria invading the periodontal tissues, and secondly, we could have the host inflammatory response to the oral bacteria, causing accumulation and release of inflammatory mediators. And of course, we also could have the adaptive immune response, which is stimulated in response to persistent inflammation in the periodontal tissues, cytokines, for example, being released. And I think probably this is key in, for example, dementia, when our immune system becomes deregulated as we get older. There's a fantastic paper by Kaesbaum, which is a meta-analysis, systematic review of meta-regression, between 1990 and 2010. And this shows that periodontitis affects more than 50% of the adult population and 60% of those over 65. In the severe forms, it affects 11% of adults. And this is the big one for me. It's the 6th most prevalent disease of mankind. That's amazing, isn't it? And when we think about it, the majority of periodontal conditions, gingivitis and periodontitis, are derived from poor oral hygiene and completely preventable. Quite frightening. If we look at the prevalence and incidence of periodontal disease, you'll see here that it starts pretty early. We've got late 30s there, and again, slightly earlier for the incidence rate. So we need to get in early. We need to teach people how to brush well. I think particularly children at a young age, because usually it's the parents that teach people how to brush, the children, and I think we should really focus in this area. All now are well aware of the periodontal workshop, the World Workshop in Perio 2017. Look now at health and our move away from health for periodontal disease. So periodontal health is a state free from any inflammation. And then our gingivitis is when we have more than 10% bleeding sites. So we now have gingival health if we have less than 10% bleeding sites. That gives us just a little bit of leeway, doesn't it? Which I think we all need. Localized gingivitis, greater than 10%, but less than 30%, with probing depths less than 3 millimeters. And then our generalized gingivitis, greater than 30%, with our low probing depths. Periodontitis, I'm sure this is just a recap for you, but I thought it'd be worth doing. We now have periodontitis, necrotizing periodontitis, and periodontitis as a manifestation of systemic disease. So gone is the chronic and the aggressive periodontitis. It's one single category, periodontitis, which makes complete sense to me. And of course, we stage and grade. Staging reflecting the severity of the disease, and grading that patient's susceptibility and the speed of that disease. And this is the overall classification in this table. So if we go back now to a workshop, the 11th workshop, which was held a little bit early in 2015, we were incarcerated up here in Segovia. This is the palace that the kings and queens used to go to in the summer when it was too hot in Madrid. We worked really hard. Lots of systematic reviews come out of these meetings. We start early in the morning, 8, and we finish about 8 at night, and then we go for a meal, which sounds fantastic, but after about day 3 and you're working really hard, it's really draining. But at the end of it, it's a brilliant experience, and you'll see many of the papers that we refer to coming out of these workshops. Secondary prevention of periodontal and peri-implant diseases. And What I'd really like to focus on tonight, as I'm sure you can tell, is the emphasis of prevention of periodontitis and peri-implantitis. The vast majority of periodontal and peri-implant diseases are initiated by the accumulation of microbial biofilms on the hard, non-shedding surfaces of teeth or implants. And I put up a diagram here of the microbiome. The healthy oral microbiome is essential for maintenance of health, and it also plays a critical role in the protection from and development of disease states. If this gets disrupted, and if the biofilms are not regularly dispersed or disrupted by self-performed oral hygiene, we move from this clinical health to our gingivitis, as you can see here. And this is totally reversible. We get the emergence of pathogenic strains, and we can lead to gingivitis and perimucositis. And then in 50% of individuals, if they're genetically susceptible, or they have epigenetic susceptibility as patient-related factors like smoking, we go on to periodontitis. And gingivitis and periodontitis is a one-way arrow. So once we have periodontitis, we're diagnosed with that, we can't go back to clinical health. This is a very famous study that's often quoted, but I still like it. It's so clear. It's the one by Harold Lowe back in the 1960s, 66. And he took a number of dental students with good oral health, asked them not to brush for a period of 2 to 3 weeks, and they all developed gingivitis. After that, he asked them to brush, and you can see it totally reverted. And it's really the basis of much of our work and our studies today. Periodontitis is preceded by gingivitis, and it's characterized clinically by the loss of attachment, an attachment being, of course, recession and our probing pocket depth. And it's propagated by the subgingival bacteria, which are in turn derived from the supragingival plaque. So that's why patients need to disrupt every day the biofilm supragingivally. In fact, that's the key to success with periodontal disease, actually, people brushing their teeth well. And then we as oral healthcare professionals need to disrupt the subgingival, and that's what we do on the 3-monthly basis for our monitoring and maintenance in our supportive periodontal therapy. There's a strong cause-effect relationship between the accumulation of plaque and the development of gingivitis. So bleeding on probing is a strong indicator that we might lose teeth. And the paper I quoted at the bottom here, Schnatzel, states that teeth consistently surrounded with gingival inflammation, so that's bleeding on probing, were 40 times at higher risk of being lost than those that weren't. And that's, I think, something very important to think about. But of course, we have to remember, as always, our different susceptibilities. And you can see here, this is a photograph, or the 2 photographs of a young girl who has very good oral hygiene, but you can see here has deep pockets. So she's highly susceptible to periodontal disease. And we get the reverse. This chap here, who's 18, or he was when I took the photograph, never cleans his teeth, and he's done it for years. And although he has some gingivitis, because I showed you if you don't clean, that's what happens, he has not gone on to develop periodontitis. He has a few other issues, though, as you can imagine. So I look at periodontal disease like this. Here we have our health, we have our host, which is red, and our bacteria, which is white. We can go on to develop mild periodontitis or severe periodontitis. So when we have mild, we can have lots of microbes, and we have a little bit of imbalance. But here we go now with our severe. We have few microbes, but our host really isn't coping. And of course, in health, we always get a little bit of inflammation in that gingival clavicular fluid area. So we've always got a little bit of this seesaw occurring, even in health. Let's move now to implants, peri-implant lesions. Again, the majority are bacterial in origin. And we have other issues with implants, obviously positioning and cement retention, all sorts of things like that. But a true peri-implant lesion is bacterial in origin. And we get the imbalance again between the host and the bacterial load. And we get the development of a biofilm on that implant surface. Peri-mucositis is inflammation around the implant without bone loss, often with suppuration. So the first thing I do when I look at an implant is you look at the gingival margin, you massage the tissues. If there's any suppuration, it's very easy to see, and then you'll probe to see if there's any pocketing. And of course, if you think there's likely to be bone loss, you take a radiograph. And peri-implant disease is inflammation with that bone loss. As you can see here, this lady, well, she's hung onto the implants for a long time. You can see they were pretty long when she first had them, but you can also see that she had a lot of bone loss when they were placed. And if you think now that these were placed in the 1990s, early 1990s, I think it's quite remarkable actually that they're still in place. If we look at the word workshop in Perio, and I apologise, I've got the date wrong there. It should be, that's today's, isn't it? It should be 2017. The characteristics of the peri-implant tissues in health are properly identified in the literature, and we have deviation from this health, which is used to describe that disease. And from the workshop, this is Jack Catton's paper here I put out for you. Periodontal health is the absence of erythema, bleeding, swelling and suppuration, as I said. Pocket depths are difficult to define. We have a very clear pocket depth of 4 millimeters for periodontal disease. If we have bleeding, we are not healthy. If we have no bleeding at 4 millimeters, we are, if you've seen from our new implementation guidelines. But for implants, it's different because it depends on what the pocket depth was when you first placed the implant. So there's some variation there. The key is, of course, to record it on a regular basis, particularly when you first place the implant and over that first year. Peri-implant health can exist around implants with reduced bone support. And as I said, look for all these things. It's very straightforward: the erythema, the swelling, the suppuration, the probing depth. And as I said, there's a strong link with bacterial origin. So if I show you again with the implants now, here's our peri-mucositis, so it's just tipped a little bit, and then we go on to our peri-implantitis when, of course, we tip further. Why are implants more susceptible than teeth? Well, that's to do with the connective tissue around the implant. And as you can see here, if you look at the schematic on the left, we have a lot of collagen fibers in all the different directions. I'm sure you remember those. You know, there's an awful lot of directions that those fibers are in to hold the connective tissue tightly against the tooth. And of course, we have that junctional epithelium. In the implant, the fibers, the collagen fibers, only go one way. So I look at peri-implantitis really as a very aggressive perio disease, a severe periodontal disease. You'll remember, I just thought I'd put this up for you, that the term biological width has now been replaced by supracrestal tissue attachment, which seems like a long word, but it actually makes sense because it's that junctional epithelium and the supracrestal connective tissue. While we're on the subject of the new classification as well, you'll remember that the gingivae around the tooth or the implant is called now, that is the phenotype. We don't call it any other name. We used to call it the biotype, but it's the phenotype. Important that we stop bleeding, and bleeding is a really easy sign for both the clinician and the patient to see. Bleeding gums are not normal, and it's important that we stress this to our patients rather than thinking that there's nothing that they can do about it. Moving on from there, if we smoke or our patients smoke, what do we do about recording the gingival bleeding? And this is a fantastic paper, I think, by Ramsey, which comes out of the Burn group, that gives us some markers. So periodontally unstable patients have bleeding on probing greater than 20%. If they're stable, then of course it's less than 20%. If we have stable smokers, it's less than 16%. So if you have a smoker, you need less bleeding on probing to have that stability. We need to tailor our management to the individual's needs through diagnosis and risk profiling. And traditionally, we have often used the intervention model, but now we tend to use the prevention model, which of course must be better. So the patient has to take responsibility for their own health. We need early diagnosis, and early diagnosis means bleeding on probing and gingivitis. We don't want to wait till we get a BPE 4. The most important BPE score is 1. We've just moved off health and we need to move it back while it's in that reversible stage. Education and of course motivation. And here Jess and Louise, Jess is on the left with blonde hair and Louise with dark hair. They're both doing work in our group in Bristol, and they are looking at motivational techniques to improve oral hygiene, and it's working really, really well. And for example, what we've done is gone into NHS practice, a busy practice, and try to give people top tips on how to manage their health. So what makes people change what they're doing? You have to hook them in. It might be a question like, you may not have any health concerns, but did you know that 50% of people are susceptible to gum disease? And then there's the association with cardiovascular disease or diabetes. Did you know gums shouldn't bleed? What do you think is the most important thing you need to change in your cleaning regime? Or is there anything I can do to help you? And we have a list of these 10 top tips. If you'd like to have them, I'd be very willing to give them to you. Universal periodontal screening by the oral healthcare team. Of course, this needs to happen. And early recognition is important. The BPE is a screening tool, remember. It's not for diagnosis. It's helping us to decide if we need to go on and do a further examination and treatment. So once you've moved off a BPE score and done a 6-point pocket chart, you never go back to do a BPE. You look at the tooth or the implant, and you will do your 6-point pocket chart around it. And I think we're all very clear on the BPE scoring system and the probe that we use and what it means. And our key numbers are 4 millimeters and 6 millimeters. The BPE guidance also maps to the UK implementation of the 2017 new Perio classification, which is really important because at the moment a lot of the world's struggling to implement the new classification due to its complexity. And you are all familiar with these probes, I'm sure, whether we have a constant pressure probe or whichever one you want to use. The key is to use the same probe regularly so that it reduces your subjectivity. And the new guidance is probably 20 grams is enough, particularly around an implant, because if you overdo that force when you're probing, you can cause some damage. So all new patients, children and adults, should have a BPE, and we should do the codes 0, 1 and 2, and then we should do that at every routine examination. But if we have a code more than 0, 1, 2, 0, 1, 2, and we have a 3 or a 4, then we need to move on to do something different. So we need to move on to our detailed 6-point pocket charting. But if we have a code 3, it might be that there's just a little bit of inflammation that with some oral hygiene instruction we can reduce. And indeed, if we do that and they come back, it might not be a code 3. If it is a code 3 or a code 4, then of course we go on and do our 6-point pocket chart. And remember to look out for false pocketing from inflammation. The BPE, I'll say again, is not for monitoring a periodontal patient. It's only used for screening. And then we have our guidance as to what to do if we have a 0, 1, 2 or 3 or 4. And as I've said, plaque and bleeding is key, and we need to reduce it at a very early stage. So the BPE 1 is where we need to focus for our patients, as well as 3s and 4s, because if we stop the one developing, we shouldn't get periodontal disease. When we've undertaken our 6-point pocket chart, we can look at radiographs for our code 3s and 4s. Of course, the gold standard would be our full mouth periapicals, but a good DPT is fine. And we need to see the crestal bone and the ACJ down to the apex in order to make our diagnosis. And one of the things I would stress is that please refer early if you feel that you can't manage the patient or you'd like some advice, because so often much bone is lost. And whilst we can move these teeth back, for example, you can see here she had severe periodontitis, and the orthodontist managed to move everything back. But it's much, much better to refer earlier. The treatment's easier and the result is usually better. So if in doubt, refer. As I said, the emphasis was on prevention. And if we look at our classification, which we have documented in the UK implementation of the workshop, we have periodontal health, which the diagnosis will be periodontal health. The gingivitis, which will develop if we leave plaque on the teeth in the majority of cases with periodontitis, which is reversible at this stage, and the diagnosis is gingivitis. But now when we go on to have periodontitis, we can either be stable, we can be in remission, or we can be unstable. And that's what you need to write down in your notes. If any of you have not seen the implementation guidance, we've published it in the BDJ with a series of case reports to help you to use that classification. And also the BSP has produced a lamina which we are hoping to get to every practice. So if you haven't had one, please ask us and we'll send you one to help you through the implementation of the new workshop. And make this a usable tool for you. And remember, it's the worst site in the mouth that you record with regards to bone loss. So we have periodontal stability. That means we can then go on and build. It's the foundation stone for our advanced restorative care. And really, advanced care is contraindicated if we have an unstable periodontal condition. The one thing I would say, though, is it's much better to have, for example, a cantilevered resin-retained bridge than a partial denture while we're getting that stability, because we want to reduce plaque levels. There are limitations of self-medication without diagnosis. So people will buy, for example, mouth rinses, and I think this can be very confusing when you read on the bottle. It suggests it might achieve one thing and it might not. So I think patients really need help from us in order to know what to buy. And in fact, I think it can be pretty confusing for us as oral healthcare professionals sometimes as well. Tailor the treatment to the individual's needs. So we need to invest in educating and motivating our patients. So this is time consuming, and hence why we came up with the 10 top tips in order to try and make this easier for dentists to change people's behaviour, which of course is not easy. So what do we have in our armoury? Well, we have, of course, mechanical plaque control, which I've said is the most important, and we have that as self-care, toothbrushes and oral hygiene aids, and of course, professional mechanical plaque control. It takes 48 hours to get gingival inflammation. So why do we say people should brush twice a day then? And the answer for that is we're pretty bad at brushing, and if we brush twice a day, we should be able to maintain our gingival health. What I would say is, though, that if we ask someone to brush and they miss an area and we ask them to brush again, believe it or not, they'll miss the same area because we're creatures of habit. So what you have to do is, if there's an area in the mouth that needs improved oral hygiene, we ask the patient to focus in that area first and then clean the rest of the mouth. The first place they clean the best. And if you look at a brushing cycle, which is notoriously difficult to evaluate, the first tooth gets brushed the best and the longest. And by the time you get to, for example, the lingual of the lower right 7, we really aren't focusing on oral hygiene, and we're thinking what we're going to do next. So let's look at oral and hygiene instruction and see what value it has. So we look at this paper. This is by Frieders van der Weyden from the ACTA group, and he showed with his group that a single oral hygiene instruction, so mechanical brushing with a toothbrush, in addition to the oral prophylaxis, does have a significant but very small effect on reduction of gingivitis. And these were big studies, 6-month studies. If you ever get the chance to listen to Tim Newton, he's absolutely superb and has fabulous stories to tell about how you get people to brush their teeth with goal setting, self-monitoring, and planning. And the planning is really important. Apparently, they're the happiest people, those that plan. And he describes how you have to, for example, find a way to get that patient to change their habits, which is pretty difficult. And I always remember one of the stories that Phil Auer tells about find something in your daily routine where you can, for example, do your TPs, your interdental cleaning. For example, listening to the Archers, it's a 10-minute slot every day, and you can sit down and do your interdental cleaning while you're doing that, so that it's not rushed and it's done properly. So you have to find a way, or the patient has to find a way, to build in their oral care in a structured manner and done properly. You don't want to do it 2 or 3 times a day and do it badly, or once a day and do it well is the better way to do it. And one of the things I do when I see my patients is, when I've disclosed them, and I would urge you to disclose them because it's very difficult otherwise to know where that plaque is, I then stand right out the way. My nurse, Becky, holds the mirror with the patient, and they have a conversation about whether the patient's done the cleaning well or not. So the patient will then say, oh, yes, I think I've done well, or I haven't done quite so well. And that is brilliant, because the patient then really engages in this process. I sit right back and then come in only when we need to help at the end. And that works pretty well for me. I'm sure you've heard of Shahbaz Salim, and he's produced this fantastic document, Healthy Gums Do Matter. Again, trying to motivate patients, and they sign a consent form that they will do their best to clean their teeth. And they've showed that if you have low plaque levels and low bleeding levels, then you can move into the pathway of periodontal management, so your RSD. But if you don't have these low levels, then don't go on to the next stage. Spend time getting this right. Because if a patient doesn't know how to clean their teeth, no matter how much root surface debridement you do or surgery, it's not going to work. I have a sheet, again, one of my nurses drew this up for me, actually, and if any of you like it, then please ask me for it. And it's for the patient to disclose at home. So when a patient is good at cleaning, they're asked to put on the dye. And the key is, when you put on this dye, is that you flood it into the interdental areas. So it can't be painted on with a brush. It needs to be flooded in with like a cotton bud, and then they see how good they are, and then clean off any plaque that's there. And of course, you want to do this on a day where you're not busy, or the patient's not busy, and clean the teeth first the best they can, and then put the dye on. The EFP has produced a number of leaflets that are available for us to use. Really simple, good statements that you can use for your patients, and I've listed some of them here. So bleeding gums are not normal. If you have bad breath, you can do something about it. Weight loss, we need to discuss this with our patients now. Brush our teeth twice a day, and of course stop smoking, and ideally use a fluoride supplement with adjunctive chemical plaque control if necessary. And there are a number of these leaflets for all groups in our community. Mechanical plaque control needs to be, as I said, self-directed. We need a risk assessment, and we recommend twice a day cleaning. But as I've said, the majority of us are not good at cleaning. If we take a person brushing their teeth, they only remove 42% of the plaque, and that's Dagmar study, Dagmar slots, again from ACTA. We need to have a brush that's not too big, that the filaments are not too sharp, they have good end rounding, and brushing ideally with something like a modified bass, and for about 2 minutes. Is one brush better than another? This is fairly fine print stuff, but the crisscross angulated, which is the bottom picture, the one with the green and the blue bristles, does have slightly better plaque removal. And if we look at power brushes, the power brush for the average person will remove more plaque and will reduce gingivitis. And then again, that was Friedrich van der Weiden's work and Dagmar's. What about incidental cleaning? There are a number of products available, and the research shows that it doesn't matter what you use as long as you use it properly, as long as it isn't floss that doesn't come up so well in the systematic review. So my favourite would be the incidental brushes, and you obviously need to find the right size brush for the right gap. The commonest mistake is, because we all show our patients how to do it, but the commonest mistake is that the patient doesn't move the brush around enough and the brush is the wrong size for the gap. So what I do, I ask my patients to demonstrate to me after they've been using them for a while which brush they use, and then we can just check it. But they're the commonest things that tend to happen. That's just the paper showing that the majority of incidental aids work, but floss gets out fibres and food particles. The only time that I would suggest floss, of course, is if the teeth are very tight or we don't have periodontal disease, because we don't want to cause trauma to our gingival margins. One always has to be careful though. Have a good look at the radiographs and the clinical picture here. This gentleman walked into my clinic at the hospital, and when he shook my hand, you know, I felt my hand was going to fall off. And he was obsessed about his oral hygiene. And I hope you've had a good look now, and you can see the ACJ area and that ring around it. And if I zoom in, isn't that, well, it's sort of beautiful? It's done with precision, and that was floss. And if you look, it's not particularly clear on this picture, but he's done it on the majority of teeth. In fact, you can see that on the radiograph. So there are people that are a little overzealous, and we have to manage those as well. It therefore follows that meticulous supragingival plaque control reduces the risks of periodontal disease and peri-implantitis. Mechanical plaque control is the best for 2 minutes, but if we can't maintain really good oral hygiene, and particularly if we're susceptible, then we need to go on and look at adjunctive chemical plaque agents. And let's look at those. We'll first, though, look at professional mechanical plaque removal. So that's the scale and polish, anything that it does not involve root surface debridement. And the research shows, this is Ian Needleman's work, that a scale and polish with oral hygiene can improve our periodontal condition. Patients certainly like it from the point of view of patient satisfaction. The evidence, though, is quite weak, but it is there. And when we go into supportive periodontal therapy, does that Does PMPR help with that? I'm just working with a few colleagues at the moment on a systematic review to be published later this year to see if it helps retention of teeth. I think the evidence will be very, very weak in this area. But Leonardo Trombelli showed in the 2015 workshop that there may be some evidence for PMPR, scale and polish, helping retain teeth. What we do know is with regards to implants that we should be seeing our patients on a regular basis, ideally 3 monthly, if they're susceptible to periodontal disease, and doing professionally and patient administered plaque control. Let's move on now to what we have in our armoury though if the patient is struggling to remove plaque. We have various toothpastes that have agents in them to try and reduce plaque levels. And ideally, a toothpaste is the best because we're using it daily. Everybody should be using a toothpaste, and it's straightforward to apply. So what do we have in toothpastes that work with regards to reducing plaque levels and being anti-plaque agents? We have our stannous fluoride, and that's available in a couple of toothpastes in the UK. Triclosan copolymer, you don't see that available so much now, and due to the fact that it has systemic effects, the way it works as an anti-inflammatory. And of course, we have our chlorhexidine. And these agents have all been shown to have efficacy in this Serrano systematic review and meta-analysis. Moving on to our mouth rinses, what is shown to be efficacious. We have our amine fluoride and our stannous fluoride. These are not available in the UK. Our essential oils, our chlorhexidine, and our CPC, which is our cetalprudium chloride. Again, from that Serrano huge paper, systematic review and meta-analysis. And if we look at the common mouth rinses that we know are effective in the UK, we've shown, this paper Boyle has shown that chlorhexidine and essential oils can work well as an adjunct to standard care. They both reduce plaque and gingivitis, and particularly over a 6-month period. A 3-month period, the chlorhexidine was better than the essential oils. And another paper by Marcello in 2015 showed, again, we can have a clinically relevant benefit from using essential oils on a regular basis. What I would say is we have to be careful using adjunctive aids long term, and we need to focus them on areas that need help in the mouth. For example, I might use them on interdental brushes and just focus on certain areas. And again, round with implants, I might focus on particular areas with our interdental brushes dipped in mouth rinses. We have an important role for oral health care as a team in the practice. And for those of you who work in practice, I'm sure most of you do, your nurse and receptionist are as important as any other member of the team, because as you walk down the stairs, or the patient walks down the stairs, it's amazing what they will tell you, what perhaps they didn't take in, they couldn't focus with what perhaps the dentist has said. So we all have a role in promoting health. Also, the patient's really important. We're a team, but that patient has to be part of that team too. Early removal and control of plaque is crucial to success. As I said, the majority of periodontal diseases and peri-implant diseases are totally preventable. But I think that's really important. If we manage a patient by stopping the bleeding early on with a gingivitis or mucositis, we can prevent bone loss. Mechanical plaque control, of course, is the foundation stone, but we can use adjunctive chemical or hygiene measures, and I've shown you the ones that have efficacy. And a scale and polish on its own isn't good, but with education and behaviour change, again, that has merit. We need to record what we give the patient with in terms of our information, our leaflets. As we know, many of the negligence cases involve periodontal treatment or querying the treatment. So if I were you, give patients a mouth map, show them where to use the interdental brushes. Many of us have cameras now, take photographs of the gingival margin and write down what you've done or in some way record it. We have our Good Practitioners Guide, which we are updating in the BSP. I think it's a brilliant, it's a textbook really, and goes through things very clearly, I think, and bullet pointed. Stress the links to systemic diseases with patients as well. If a patient requires monitoring and advice, again, tell them what you're doing. I think photographs are amazing. Make sure you consent your patients properly. And if the patient fails to improve, then this really needs to be written down as well. And if you're struggling, then refer your patient. To conclude, for those of you that are older will recognise what I've put on the presentation there. We take a history, we do an exam, we look at risk factors, special investigations, we treatment plan, and we look after the patient as a whole. But what I'd like you to do, following on from tonight's presentation, is to think bleeding gums are not normal. Intervene early. BPE1 is the key. It's the most important BPE score. Individualise, find out what that patient needs, how do you hook them in, which areas are they struggling with, and focus on that. We can use adjunctive chemical aids, and we need to reiterate. We tend to forget, and when we do something every day, we sometimes get into habits that aren't quite so good, and we always need to go back and look at what our patients are doing and making sure they're cleaning optimally. Prevention is the key. Periodontitis is preventable, and self-performed oral hygiene, again with education and oral healthcare professionals supporting and diagnosing and risk profiling is the way we need to go forwards. And then we'll have success, which of course we all want. Periodontitis is a major public health issue. It causes tooth loss, aesthetic problems, poor nutrition status. It affects our speech. People can't smile, and people that smile are always happier. That's what the research shows. We have a huge cost, both in time and in money. And as I said, the majority are preventable. Thank you for listening this evening. I mentioned the conference because I'm very proud of our society, and I think Mark Ide, as president, has set up an amazing conference along with Tamsin, and we look forward to seeing you there. And I'd like to finish just with a little video. Thank you.
Thank you, Nicola. That was excellent. We've got a series of questions that have come in. While I remember, just one point that I wrote down, anybody who wants access to the flow chart before it arrives through your letterbox, don't forget it's fully downloadable on the BSP website in the publications section. So feel free to access that there, but you will be getting something through the post hopefully in the next couple of weeks. So we'll start working through the questions. First question from Alison. So what bleeding scores do you recommend when BPs are 1 and 2 if you're not doing a full mouth pocket chart?
If you are looking at just bleeding scores, we can give you, or I can give you a chart to fill in, just to highlight in those areas in boxes around a tooth. So I tend to do 6 points around a tooth, but I can give you a chart, Alison, if you email me through the BSP website. I'm the secretary. Then I'm the one that answers the questions. So please do that.
Great stuff. Questions come in. So if a patient has no 4mm pockets with bleeding on probing, but their bite wings show what looks like midline bone loss, do we stage and grade as once a perio patient, always a perio patient. We can't see the apex, but are we justified in taking periapicals, or are we saying the patient is stable? Sorry, it's slightly
Right.
long-winded.
I think I know, or I hope I know. So the first thing we have to work out here, if it's a perio patient or not. So if it's a perio patient, then there's been a history of periodontal disease due to the bone loss, or it might be a patient with reduced bone loss or reduced periodontium. So it could have been crown lengthening or orthodontic treatment or something like that. So you need to work out if it's a perio patient or not due to that bone level, and you'll work that out from the history and looking at the patient. If you have got less than 3 or 4 millimeter pockets at that stage when you see the patient, then they're not bleeding, then it's going to be stable. So at that stage, I wouldn't go on and do further radiographs. I would do it when they're unstable. I hope that answers the question. Yeah,
I think it probably does. This question could take a long time to answer, and you may not be able to remember all 10 of them, but somebody has asked, Stephen has asked, what were the 10 top tips for patients?
Yeah, we did them. So Jess has done this for her PhD. I'm sure she would love to talk to you about it because she's passionate about it. We drew up 10 top tips to make it easy, and we did this in general practice. So we put it into the DFT program, and we wanted to see if it worked. We know NHS dentistry is busy, and we wanted something simple that the dentist could choose if they wanted to use one of our top tips, or they could give them all to the patient, but something to change that patient's motivation. And you've got to find the right one for the right patient. So again, if you email me, I'll put you in contact with Jess, and I'm sure she would love to talk you through it, and we'll give you the list.
That's perfect. That sort of answers the next question. It wasn't really a question, more of a statement, but just relating to the fact that obviously on the NHS, time and financial constraints are very difficult, and how we're going to get this behaviour change across in the very short time spans they have with patients. But I think hopefully you've answered that with that sort of brief approach.
Yeah, and I think Shazad's work's brilliant up in Manchester, and he says, yeah, as you know, Ian, and he says, and this is supported by a lot of other people, and it's government supported as well, that if the patient is not signing up, then stop at that very early stage. Don't go on and do the advanced work. And what that means is you then have time to focus on oral hygiene, and that is completely acceptable. But just write it down so that you've got that documented in your notes.
Yeah, I couldn't agree more. I think it's one of the only times I've ever seen a very distinct pathway for NHS Peri-OK using the UDA system. And they have that concept, don't they, of the engaged and non-engaged patients. And the bar's not set so high that it's unachievable, but they don't want to treat patients unless they achieve a certain level of engagement, which I think is, like you say, gives it time then to maybe do that behaviour intervention.
Absolutely, and I think what's important is that we recognise this. We don't have to go on and do our complex work if that oral hygiene's not right, and that's completely acceptable because we know it will fail long term. So I think Shazad has got it absolutely right. He works in a busy NHS practice, and he's making it work. The same with Jess. When she did her work in practice with the motivational interviewing, we have shown, and we're just about to publish it, that it can work in NHS practice, and people and patients can be healthy. We've just got to help each other with the right tools to make it easy.
So a slight technical point, do you feel it's better to disclose the patients after you've asked them to brush so they can see what they've missed, or do you get them to disclose first and then brush the disclosed plaque away?
Yeah, so in practice, most people have cleaned just before when they come and see me, and therefore they in fact, some of them you can even see the disclosing solution still around the gingiva. So for me, I disclose everybody, and every time I do a lecture, I ask people to put their hands up if they disclose patients or not, and the majority don't. And I think that's a huge mistake. I know the reasons why, but I do it for everybody. They're coming to see me. I need to get a result. They want a good result. And it doesn't matter that they have a bit of disclosing solution on afterwards. I mean, they can brush it off. And I think it's crucial. It's not crucial actually from a dentistry point of view, because as we know that it's the inflammation and the bleeding on probing that's the most important, not the plaque, because everyone can forget to clean, or we can choose not to. But it's a really good way of showing the patients where they're missing. And if the question was about at home, what do I do or suggest? I suggest that on an evening when they're not busy and they haven't got white towels in the bathroom because it stains like crazy, that the patients clean as best they can, then put the dye on, and then clean the areas of the problem.
Great stuff. And I think you've answered Rebecca's question about how frequently you do that on a day-to-day basis. I think you pretty much answered that.
Once a week. Yeah, we mustn't get obsessed about things, because that's stressful, isn't it?
Yeah. Okay. Would you do a bleeding score during the examination appointments to be able to give the diagnosis, or do you wait for the hygienist to do the bleeding score when they maybe do the 6-point pocket chart?
I think it's up to how you work in your practice. I really don't mind as long as it's done. And the way we do it, or I do it, is because it needs to be quick and efficient. We all like to work like that. And just get a highlighter pen and just run over the pockets that the numbers that are bleeding in the pocket chart. So I really don't mind who does it. I think personally I do it at the time I was doing the 6-point pocket chart, because I think it's more efficient.
Yeah, it was interesting. I was teaching a group of DF1s only last week, and chatting to their TPD, who's a very experienced NHS dentist, and he was saying that they delay their pocket charts until the patient's cleaning better, but enable to allow him to make a diagnosis early on. When he does his BPE, he then just very quickly eyeballs the bleeding that's come from the BPE. And he said all he's got to decide is whether it's more than 10%, because the minute it is, it's classed as unstable. So he's doing a very crude assessment based on the BPE. He's doing his x-rays, he's doing all that information gathering, but the detailed pocket chart he's doing at a later date. And that was his way of still allowing to be able to make the diagnosis, which I thought sounded eminently sensible.
It does. We have to be very careful, particularly, or I do, particularly giving this webinar, that I'd have to say probably put provisional diagnosis, because you haven't done the 6-point chart. But I totally agree. And anyone that's worked in this field like you and I have, Ian, for the years we've done it, we know when that patient comes in if they've got periodontal disease or not. It's so obvious. But from the point of view of medical legal documentation, I would suggest that you put provisional until you do the 6-point pocket chart. But you're absolutely right. Yeah.
That sounds good. Yeah. Okay.
Differential diagnosis. Another word before your diagnosis.
Yeah, absolutely. Somebody's asking for your email address. If you, for the person who's asking for Nicola's email address, if you go to the BSP website and look through the council members, you'll find it there.
Yes, so. Or it's if you look me, it isn't on the presentation, I don't think. Sorry, I could have put it on. Or I work in Bristol, so if you just look me up in the Bristol Dental School, it's n.x.west. There are 2 Nicola West, and we get confused fairly easily. So it's n.x.west at bristol.ac.uk. But through the website, the BSP all comes to me as well.
Do you know, I always wondered what the X stood for, Nicola. I thought you had a middle name.
Exania.
Okay, a question from Marie. I have a new patient with active perio who had implants placed in the last 6 months. I have concerns about the potential to develop peri-implantitis. Spoke to the implant dentist, and they felt that water pick would be adequate for incidental cleaning around the 2 implants with conjoined crowns. This person, Marie, felt that TPs and superfloss would be more effective. Do you have any thoughts on the oral irrigators?
The research shows that all incidental cleaning aids have equal effectiveness, according to Dagmar's systematic review out of ACTA, which is a very good one. I have my personal view. My personal view is I think the water picks are very good. but so are interdental brushes, and you've just got to get the right size brush and do it every day, and it's that attention to detail and being able to do it properly that's most important. So that's where the oral healthcare professional comes in, to make sure that the aid that the patient is using is being used correctly.
Yeah, I think my attitude with my own patients has always been, if they can't or won't use brushes, then it's better. Yes. The oral irrigates are better than nothing. But
I agree. The one I do like for the, when teeth are very close together and there's very little bone, particularly upper molars, and you've lost that bit of bone and it's notoriously difficult to clean. You can't get the brush down there, and I think it's fabulous for those sort of areas. So really tricky areas, I'd say yes. 9 times out of 10, I think we can achieve really good oral hygiene with brushes.
Yeah, I agree. Okay, it's less of a question and just more of a very valid point from Penny, just saying that you mentioned the OH tips behaviour change intervention, and Penny was just pointing out this was developed by the Scottish Dental Clinical Effectiveness Programme, and it is available free on the SDC EP website if anyone wants to have a look at that. And I know that document, it's a fantastic piece of work, and I would encourage everyone to go and have a look at that.
Yeah, absolutely right, Penny. Thank you.
Great question from Kay. This has come up a number of times actually on a number of the webinars, and people probably not getting quite the full answer. With regard to the new classification, how often should we be making the diagnosis or re-diagnosis? Do we diagnose the patients every time they're seen annually? If we see them on a quarterly basis, are we diagnosing them every single time we see them?
Yeah,
what's your take?
It's a really good point. I was actually discussing this with another specialist today. It's a very interesting point, and it's not really documented anywhere, is it? And I think we need to think about this really carefully. Obviously, we'll do the diagnosis the first time we see the patient, but things do change, and whether we're in stability or not. So I think, and I'm just thinking about this myself. As I said, it's something that we need to write about. I think, particularly BSP, we ought to write something about this. I think we need to look at how often we see our patients, and if we see them once a year, then we can look at that diagnosis and whether it's changed each year. If you're doing a 3-monthly visit and you're looking at your pockets and you're bleeding, of course you can do it then. I think it's an area which is a little grey and needs thinking through. And as I said, we are way ahead of the rest of the world at the moment, which is lovely. Most of Europe, they can't implement the new classification because it doesn't, as it stands, doesn't map to, for example, the BPE, whereas ours does, our implementation of that new classification. And it's a working document, and it's something that I will take back to that working group and we will document. I think we mustn't be too black and white. We need to be grey about it, but it's something and a really good question that we need to think about.
Yeah, Manoj has just made a valid point that he thinks that when it was discussed at the working group, that if you every time you do a formal reassessment and you've got the data in front of you, that was probably a time that was worth making a diagnosis statement, maybe.
I think so. Only we have to be a little careful, don't we, how often we're going to do this. And I think we mustn't do it too often either. So I think it's something that we did discuss. However, I think needs some further discussion, and we can amend the information and change it, and it will grow as we think of these things. And it's something that we need to give guidance on.
Yeah, very much so.
Yeah.
I said, quarterly would be overkill. Whether we do an annual reassessment for our supportive care patients, that's probably
I agree with you. I think probably that would be a good. You can always do it more frequently if you want to, if you feel you need to, but I don't think we need to overdo it.
No, I know. I think we can definitely overthink this, can't we?
Yes, but really good point. Really good point. And I was only talking about it today, which is.
It comes up on a lot of our courses. When I'm teaching this stuff with Phil, we get that question asked an awful lot.
Yeah.
Question from Carol: if a hygienist puts the diagnosis, should they write that this is a provisional diagnosis? the dentist that Carol works with has not started to use the new system yet, and she doesn't always have the radiographs to check the bone levels on the radiograph. Would it be appropriate to put a provisional diagnosis in the absence?
I think so. I think, sorry, I've got to remember the order in which you asked the question. So I think, oh yes, I think this is really important. We don't have to start using the new classification and the implementation of it today. I think what's important is that we familiar ourselves with it. So I've just taught it to all our students now, and we will be bringing it in over this year. I think you've got to get your head around it. It's actually quite simple, but it looks quite complicated. It's all to do with the bone levels. So I think, yes, a provisional diagnosis would be good if you don't see the radiographs, because you need to see those radiographs. But bring your new classification in when you feel comfortable and you've looked at the documentation, for example, those BDJ papers, and practiced so that you feel confident about bringing it in. So as I said, we're ahead of most of the world. So practice and bring it in when you're ready to. And if it's the end of the year, that's fine. You know, there's no fixed timelines on it.
Yeah, we're recommending anybody who's been on any course at all relating to it to take it back to the practice, pull out some radiographs and challenge the team, you know, to do it in a practice meeting, and try over a couple of months to develop a sort of a level of continuity within the team. And a lot of people are feeding back that that's working well for them.
Yeah, I think, I don't know if people heard the webinar the students did in Bristol, you know, for students, by students, and they came up with some really nice, it was beautiful. And I'd recommend anybody or everybody to look at it. It was really nice tips like, oh, well, if the patient's younger than the bone loss, it's obviously a C. And, you know, you do, like we were saying earlier, you start eyeballing things. And there's 4 words to do, isn't it? It's generalized or localized or incisal molar. Number 1. Number 2, what is it? Periodontitis, nearly always, isn't it? Or gingivitis, really simple. Stage and grade. It's much easier than I think you initially think it is.
Yeah, we keep reminding people that for years we've done the mild, moderate, severe, localized, generalized, chronic, and aggressive. It's a variation on what we've been doing for a long time.
Yes, and I think it's not a new message to take full mouth peri-implant or a DPT. It's not our messages aren't new. We're just refining them and reiterating them really in a different form. But it isn't that complicated. Have a look at the BSP laminated sheet. And what I do with all the students and the staff, we just have it up on the side. And as you say, we practice and we look and we will have a go.
Yeah, absolutely. Okay. Sort of reinforce back from Carol again. She's thanking us for the answer. How can she explain to the dentist that she works with that this system is here to stay and needs to be used? She's happy using it, but without the radiographs, she's struggling. The dentist doesn't want to use it.
She should have access to the rate. I presume there are radiographs, and
not according to the question, not always.
Perhaps she should suggest there are.
Yes, I think I would agree. I think in terms of is this here to stay, this is the BSP's implementation of a world workshop that will not be repeated anywhere anytime soon. And so it is the most contemporary, up-to-date classification system, and it won't be changing. So the dentist needs to keep up to date, is the message for Carol to take back to the practice. It will not be changing. It won't be going away. Yes. And radiographs are a fundamental, as they always have been, as you've just said, Nick, are a fundamental part of periodontal diagnosis, and without them, medical legally very vulnerable.
In fact, I don't do medical legal work, but from what I've seen, Ian, you might be able to answer this better, but 9 times out of 10, there aren't radiographs or the oral hygiene or communication. It's one of the key areas where people are sued on. So, this isn't new, as you say.
No, it's part of good practice. It's part of our diagnostic process. It's like you say, it's informative for the patients, and the new classification will not let us work without them anyway. So I think that Carol's got a bit of work to do with that dentist, but keep up to date keep up to date. They
Yeah,
must.
well done, Carol. Well done you
Yeah,
for
good
pointing
on
it
you,
out.
Carol.
And yeah.
That ultimately is the end of the questions. So that I'm going to wrap it up for the evening. I think you'll all agree it's been a fantastic evening, and Nicola, you've been very entertaining and informative. I'd like to thank everybody who's attended. We had over 100 people attending live tonight and over 300 people registered to watch this at a later date. Final thank you to J&J, and like I said, just once again, thank you to Nicola for her time this evening and a superb presentation. Thank you, Nicola.
Thank you, Ian. Good night.
Good night, everybody.